So we wanted to do some research and talk to the service providers to say, what were other things that we could do to actually recruit and retain people in home care. What we found is you had workers who spent, hours, days by themselves, working independently with families, very difficult circumstances at times, no one really to talk to. They talked about the loneliness, the isolation. They might go days without seeing another colleague. If they spoke to their supervisor, it was on the phone. And so when they encountered situations, and they started telling us the stuff that they were carrying.
Within the community, there's an incredible amount of isolation in providing care to clients and patients living at home or in assisted living facilities, simply because you may not see another healthcare worker for weeks on end. It's important, I think, to bring people back together, having somebody's voice from PSW, another voice from assisted living, another voice from the nursing agencies, to kind of enrich the conversations that need to happen.
A lot of the role that a PSW plays is a very ethical role in allowing people to do activities of daily living. So a PSW often has a lot of sometimes ethical issues with regarding changes in their care, changes in observations of the people that they care for, how that impacts the care they provide, and the ethical choices they make. Do they stop providing care? Do they recommend the person go into long-term care? And how that impacts the family and everyone else. So there's a lot of ethical issues. What we find is that PSWs will suffer with these ethical dilemmas internally, and they'll internalize them, and it brings their quality of work down, it brings their quality of life down.
Historically, they're the ones that had these terrible sensations in their stomach and didn't know what to do with it. And the fact that, oh, you mean you felt that too, but they didn't have the ability to articulate what was necessarily wrong. And so with bringing it into our organizations, it's allowed them to be able to share in a way that they feel that they're contributing to the care of that patient.
Community wasn't on the map.
No.
Right? And even when you Googled in that stage, even now, sometimes, it's better now, you would Google community ethics, all that would come up were community hospitals.
It started out really focused on the home care in Toronto, and home care being at the time the Community Care Access Centre and the service providers that worked together with the Community Care Access Centre. And then it started to grow. So it started to include long-term care, community health centers, so basically anything outside of acute care.
It was a group of people who got together from varying types of organizations who provided care in the community. Our guidelines were such that we didn't limit who could come in and join our network, and I think that was instrumental in allowing the network to grow the way it has with so much diversity in it. We did not, have a criteria to belong to the network that you must be A, B, or C. Once we created the framework and the bookmark, and we brought it back into our organizations, testing it and starting to use it, and what was so wonderful about the framework was that you could use it for any type of a situation. It wasn't framework that was designed that only worked in healthcare. It worked for everything, and we did some of those tests in our own organization, by bringing senior management together and talking about a financial issue or talking about something different, to say you can still use that same framework even though it's not a healthcare issue.
Keeping it simple, being practical, using case-based learning, having peer mentorship, which is really what that was all about in terms of, having individuals do this sort of acting through case-based work was really and continues to be an incredibly effective way to be able to scale and spread.
In those early days, I think that the biggest change we were able to make was helping people recognize when they were facing an ethical dilemma.
That's right.
And how to recognize it. So then giving them tools to actually manage it.
That's
it's
right.
still And just describing it to people to say, when you get that kind of niggly feeling in your gut, that's most likely unethical. Like, just how do you recognize that you're in a situation where you might need some help? You might need to draw in some peers or a supervisor just to help you through it.
And what came out from the framework, as we mentioned, is the acronym IDEA that was created by the committee, and that worked well, IDEA, and it's still functioning as just the basis of how we approach solving ethical, so it becomes a ethical, sort of like a forum for ethical issues in the community. So no matter at what level, for frontline staff and for accounting, for business, for management, we just apply that idea and then work it out. And like ethical dilemma, you don't really have to come to a solution, but then you just sort of have a framework to work on or to make it easier. And I find that fits in.
So one of the things that having the tools from the network is that ability to just pause and stop and bring people together. And the other piece that I have found really helpful, and the support that you get from this the network, is that obviously, yes, it's about the patient, that's the center of everything we do, but the ethical distress that our personnel feel in situations needs to be acknowledged and explored, and the toolkit really allows, the IDEAS toolkit really allows that to happen. And it allows people who sometimes will go into the conversation thinking that they can go from A to B to C very quickly, realize that in the group that there's always different perspectives, and there's it doesn't mean that it's right or wrong, it's just different perspectives, and it allows people to have that conversation and to be heard.
You didn't need to have a degree in bioethics to be able to understand how to use the toolkit, and within our own organizations, people come and go from committees, and we have ad hoc meetings, and so no matter who would be sitting at the table for that particular discussion, they were able to follow the process. We didn't have a lot of guidelines around many things, and legally over the last 15 years, so much has changed, and people are now able to live at risk legally. And what does that mean out in the community? With the legalization of MAID, that has changed a lot of things in the community as well. So I think that the framework is still there and still works no matter what the changes are.
So I think often in ethics or any discussions of morality, it's easy to kind of go down the proverbial rabbit hole and sort of lose focus on what the true issues are, what the principles that are conflicting, sort of what's at play. And so I think the IDEAS framework that we've adapted has been super helpful to frame the discussion around ethical issues. In the work that we do, we're making very difficult decisions on a constant basis. And so I think having the ability to work through those decisions and work sort of within the gray, it can help you to at least feel more okay with a decision that may not be 100% in everybody's best interest or 100% sort of resolved, but that you did make the best decision you could in a difficult environment.
Moving forward, the healthcare system is changing drastically, but the ethics framework continues to be a wonderful guideline for us as we are going into the sphere of what does telemedicine mean, and what is the impact of that, and how does the ethical framework address some of the issues that might arise with that. With the development of Ontario Health Teams, we can look at some of the changes in the context of the framework, and where are there pinch points? And we're all speaking the same language, because many of the organizations that are involved with this are also members of the Community Ethics Network. I think in a way it puts us all on a level playing field. There's that transparency of communication. Using these case studies, every one of us, I think, with the case studies would go, oh, that could happen at my organization.
I think it provides people who work in healthcare a different lens with which to tackle problems. And ethics, I find to be a very human approach to the problems that might be faced, and gives structure to some of the important values that we often all in society have, or maybe individuals have, and allows us to focus on those values and trying to understand the perspectives and values of others. Knowing that there's others in the room struggling with the same issues, I think helps you understand that this is the messy part of life, that you can't hide from it, that you've got to start thinking about how to solve these things. Plus, you have new colleagues that you can reach out to help you solve some of these.
When you're talking about patient care, I think there are some real core values that we all share as healthcare providers, and it anchored us to them.
Part of the beauty of the tool is that it is also, to a large extent, non-linear. Having the sort of specific principles laid out, having the opportunity to revisit the different sections of the tool, it gives you that opportunity to kind of check some of those biases, and especially if you're doing it with other people and having that opportunity to kind of see different perspectives and get different opinions on an issue is particularly helpful in the tool. So while I think it's useful to use it on your own, I think it's that much more useful if you can use it within a group who maybe doesn't have as close a connection to whatever the issue is.
I think of, healthcare really is a misnomer. It's value care. And so what do you value, and how can I, support that or not? When we have conflicts, it's usually at the level of values, but it's hard to recognize that that's the level, the stratosphere that we're having our challenges at. I think it really does demystify to say, there's another language you can use that will help you to enrich an understanding of what's really going on here. So the safety of bringing people together to talk about, hard issues, like what do we do, how do we respond to this idea of risk in the work that we do at all levels, is so important, and at least can open up the dialogue. How do you take it forward from there? What I like about, what I've seen with SEN is that there's, the idea of pushing forward some tools to get, to listen and to get the input of the people working within, the community, to input into the tools that are being created to help service, providers, do what they can do better.
It's part of our everyday life, whether we want to call it ethics or not. It's part of what we do, and it's nice that, having these conferences or these one-day workshops where people are able to get together and share these stories. And I looked around today and I saw how much diversity was in the room there today compared to the first couple of meetings that we had, way back when.
The discussion this morning was unbelievable. It was so sophisticated. The discussion was at such a high level. We've already gone beyond clinical ethics there, and now we were talking about organizational ethics tools that the people could use with their staff to make decisions, resource decisions, priority decisions, at the community-based level.
It was very simple when you had a house and a hospital setting and or a nursing home, but stretching that out into many different types of living for people along with that diversity, and we have to be able to figure a way to be able to still provide the care, because the network is now grown to the number that it has, that we can rest assured that other people will move forward with stuff that was done in the initial stages.
As soon as we started to get a few members, and then word got out and more members, and more people were sending personal support workers and nurses for training and education and support, the fact that the tools that were developed through the network are now used internationally, I think just understanding the impact overall has been huge. So I think it's a source of pride for those of us that were in that founding group to say, we actually founded the field of community-based ethics.
Right. You can still see the passion along the way, like people change, that was in it, like in terms of move on and other people take over, but it still has that same passion, even today.
The timing was very interesting because to my knowledge, it's one of the only coalitions that survived all the organizational changes that have happened, including hospital hospital restructuring, and the LHINs. They were all gone. None of them made it with the boundaries and everything, except the CEN. It kept on going.
We knew that the future of healthcare was not in hospitals. It was really going to be in community. So we had the opportunity to start building that capacity for the future.
Not that that was a popular concept. That was pretty threatening at the time.
I think as well, though, at the time we talked a lot about the fact that we didn't see this. We didn't see an end to this.
No.
We didn't see this as being a short-term fix. We didn't see this as being something that we were going to, offer up for 5 years and then turn off.
Did anybody tell you at the end of your 2-year co-chair commitment that you would be there 12 years? That's an example of that.
We kept trying to fire each other, but